Want to know how we can be most precise about your risk of heart attack? Stay tuned and I'll tell you how. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warrick Bishop and welcome back to the Healthy Heart Network. Today I'd like to discuss how we go from population-based risk assessment to individual-based risk assessment. What does that mean for you? What's the science behind it? I'll be talking about scanning the arteries of the heart using a CT scanner to help identify the health of the arteries. Let's take an example. But before I do, I just want to show you what we're looking at when I'm talking about scanning the heart. Here are some images of the heart, two different patients. You can see little white spots that are here that are clearly not here. These white spots are what I'm going to talk about as a representation of something going on. I'll cover that in more detail later, but let's just start with that. The example I'd like to share is Karen, a 60-year-old female who is fit and well. No significant risks other than a high cholesterol. Let's have a look at that. Her total cholesterol was 9.1 millimoles per litre. This is in the order of 350 milligrams per decilitre. Every doctor she'd ever seen had wanted to put her on tablets to lower her cholesterol, and she wasn't keen on that idea. We talked about her having scanning, and she was pretty happy to proceed with that. Here I've put up her risk factor calculator, which estimates her risk as very high. But when we scanned her heart, you can see there's no little white spots there. She had what we call a zero calcium score. Now, a zero calcium score is a very reassuring negative predictor for an event. This means she's at low risk, at least into the short to intermediate term. This allowed us to have a conversation with Karen about holding her medications but putting in place a follow-up strategy to keep a close eye on how she progressed. The other example I'd like to share is a contrasting example. Penny, who is a 52-year-old female who had a terrible family history. She really didn't have any other significant risks. Her blood pressure was okay and her lipid profile was pretty good as well. This is her lipid panel. Her cholesterol's up a little, but not that bad, and her risk calculator estimated her risk at 1% in 5 years. She got a green thermometer for that, meaning that we wouldn't think that treatment was indicated. You might note from that risk calculator though, that it makes no account of family history. Anyway, I spoke with Penny about the potential pros and cons for her having imaging, and she was happy to proceed. When we did scan her heart, this is what we saw. We did find calcification in her arteries and we measured it in all three major arteries. She had a calcium score that put her above the 90th centile for age and sex. When I gave her that result, she burst into tears. She had been terrified about the family history. But what we did was that we now were able to make a plan. She understood what she was dealing with. We knew what her risks were. We've now got her on all the appropriate medication with very close follow-up. And now that she's come to terms with dealing with those results, she is far happier to have found out that she was at risk before an event rather than waiting like the rest of her family. The last case I'd like to share with you is Paul. He was a mid to late 60s male who was slim, fit, very active, in fact prided himself on his exertion and exercise capacity. He came to see me because his brother had had a bypass operation and quite reasonably, he was concerned. His lipid profile was fairly unremarkable. His total cholesterol was little more than 200 milligrams per decilitre or 5.5. But this was his cardiac CT scan. You can see very clearly rust in the pipes. In fact, enough rust in the pipes that really warranted being put on appropriate therapy to reduce his risk of a problem in the future. Well, what does all this information mean? And what did it mean to these patients? The information from scanning the arteries showed that Karen had a high cholesterol but nothing in her arteries, though risk calculators would have estimated her risk as high. Penny, who looked incredibly average in terms of her lipid profile, except for the family history, had a calculated risk of 1% in 5 years, a low risk, but her arteries looked terrible. And Paul, who was fit and well, had terrible arteries just like his brother, though on the outside looked a picture of health. How valuable do you think this sort of information would be? So why not this sort of information for everyone? In fact, it is for everyone who's an astronaut through the NASA project, and it is for everyone who's President of the United States of America, but it's not everyone else. And why not? Well, it's partly because medicine and the community of doctors have a conservative approach to implementation of change. Generally, they want to see evidence around the implementation of a particular strategy, like scanning the heart. The problem with that is that gaining evidence can be quite difficult. And the sort of evidence that people want is called outcome evidence through a randomised controlled trial. This means that you take two groups of people who are very similar and put one group through an intervention and compare it to the group who don't have the intervention. Well, randomised controlled trials are fantastic, and if we could do them for everyone and every question we ever had, that would be ideal. But it's not that simple. The trouble is we deal with so many variabilities and there is so much complexity that we sometimes can't be sure if the trial will answer the question in our particular situation. What if we're using a medical trial that was conducted in a hot place but we live in a cold place? What if we're dealing with a medical trial where they assessed vegetarians and our patient is not a vegetarian? What if we dealt with a trial that was dealing with people who didn't drink any alcohol at all, but our patient does drink alcohol? What if we dealt with a trial that was done in China, but we're in Iceland, or our patient is from the Pacific Islands? Sometimes we just can't have all the complexities of a situation answered through a trial. One of the other things that is difficult with a trial is that there's a variation of response within that trial. So we might be able to demonstrate a standard deviation or distribution curve which shows the response of the average within the population. But what if the patient who we're dealing with is a jockey or a basketball player, someone who would sit 2 standard deviations from average? Can we apply the same information for them? Occasionally, we can't do a randomised study because the study's not being done. We know that parachutes work intuitively, but there hasn't been any research. We haven't randomised people. The man says, "Wow, what was that?" The woman, "Oh, that's Simon, first-time jumper, refused to use a parachute because he said there was no evidence that they worked." Sometimes poor study design can limit the role of randomised controlled trials. Randomised controlled trials can be conflicting in their conclusions. What do we believe? Niacin, or the role of nicotinic acid, is a good example of that. There was a trial done approximately 20 years ago called the HATS trial, which showed excellent outcomes for the people taking the supplement. But in recent time, 2 trials called AIM High and Thrive have contrary results. Lastly, randomised controlled trials are subject to people tampering with the results for personal gain. I'm not saying that occurs very often, in fact it's very rare, but it can distort the database. So we can't live in a perfect world where the evidence base asks all the questions we need answered for the individual sitting opposite us. That's where the art of medicine comes in. So what is the art of medicine? Well, it involves the practitioner knowing the evidence base, being familiar with the studies that are out there, the practitioner having experience in the field, but also assessing the individual sitting opposite them and knowing their needs, and then having the skill and ability to bring it all together. I like to imagine evidence-based medicine as a universe where we'll never understand all the boundaries, But there are fixed points. I like to think of your doctor as your astrologist who understands where the fixed points are, the stars and the moons within that universe. And each patient has a different set of fixed points that need to be brought together. So for some patients, your doctor may draw the constellation of Orion. For another patient, it could be Sagittarius. But it's your doctor who's acting to pull all that information together for the right solution, for the right reasons for you. So in summary, there are a couple of points I'd like you to take away. First of all, scanning can take us from a population-based assessment to an individual-based assessment. Think of Karen and Penny. Karen looking very high risk on her scores, Penny the opposite. 2, by bringing the most information to decision making, we can make the best decisions for the individual, the most appropriate. And 3, I'd like you to understand that there is an art to medicine. It involves the evidence, the experience, and pulling it all together for the patient. And it relies on a doctor who's able to pull all that together for the individual patient needs. So now you know a little bit about the art of medicine, let me tell you a little bit about Mick, who's this episode's case. Mick is a 50-year-old married man. He had 3 children, worked in human resources, and I was looking after him because he had a rhythm disturbance with his heart. It beat irregularly, a rhythm disturbance called atrial fibrillation. Mick was a little bit overweight, his blood pressure was up a bit, his cholesterol was pretty average, and he was first to admit that he didn't exercise a lot. When I used a cardiovascular risk calculator to look at his traditional risks, his risk of an event was estimated at 10% in the next 10 years. This is in the intermediate space, an intermediate level, and I suggested that we may want to be more precise and so suggested scanning. Well, these are the images that we found. This is his calcium score. Without any injection of contrast whatsoever, we saw a small fleck of calcification, a clue that there might have been something going on. My own practice is to look with more detail using injection of contrast to get more information if we see any calcium at all. And so we did. Look at this. Clearly soft plaque, cholesterol laden here and here, and you can see the small fleck of calcium which alerted us to this problem from the non-contrast images. There's no flow limitation there, although it wouldn't take much for this to get worse. Have a look at this picture. I think you can see really clearly the cholesterol plaque almost taking a bite out of the lumen or the inside part of the artery. These features were high-risk features. There's no question about that. And his risk over the next 10 years wasn't 10%. He was probably one of the 10 in 100 who was going to have an event. His actuality was going to be considerably different. With all that information though, we've now been able to put him on a different path. He's changed his lifestyle, he's on treatment, and he's having regular follow-up. He's lost and kept off over 10 kilograms in weight. That's over 20 pounds. That's not only given him a better sense of quality of life on a daily basis, but it's helped us control his rhythm, which he came to see me for in the first place. He's had a great outcome. It's just troubling to think of what the alternative path would have been had we not gone on and had a look. Stay tuned and we'll cover some patient questions in just a moment. Welcome back. It's time for our patient questions. And this one is, what is a family history of heart disease? Well, I see many patients who report a family history of bad hearts, or they'll report that great uncle so-and-so had a heart attack at 85 years of age and just dropped dead in the garden to everyone's surprise. But he was 85. Strictly speaking, this is a family history of heart attack in the family, but it is not the sort of family history that we as the doctors who are asking are specifically asking about. What we really mean by family history is if there has been a premature heart problem in the family, either a death or a complication of some cardiac issue related to the arteries of the heart. And when we say premature, we mean we're most concerned about men less than 50 to 55 or women less than 60 to 65 years of age having been affected. If the relative is 85 years of age at the time of their heart attack, then they've actually done reasonably well, and we wouldn't consider this necessarily puts the patient sitting in front of us at significant increased risk. The relative, after all, has lived beyond average life expectancy. If there truly are young relatives in the family who have had a heart problem, then, as doctors looking after you, we need some detail around the actual circumstances. Was the problem related to the muscle of the heart? Conditions that weaken the heart muscle or thicken the heart muscle are fairly uncommon, but can certainly run in families. Was the problem related to an electrical malfunction? Electrical issues, thankfully, are not very common, but a very important hereditable set of conditions that can be a problem and a cause of major concern in children and adolescents. Was the problem related to a valve within the heart? Luckily also, this is relatively uncommon, but pretty important to be aware of, as valve problems on the whole are amenable to correction with modern surgical techniques. The priority then is to make sure that we make the diagnosis and implement treatment before a problem arises. Lastly, and most commonly, build-up of cholesterol in the arteries, called atherosclerosis, like the build-up of rust in the pipes, can lead to coronary artery disease and does run in families. This hereditary form of increased risk of coronary artery disease, or the most common cause of heart attack, is the situation I see most in my rooms. In a significant number of individuals, there are high levels of cholesterol that run in families and in association with premature coronary events, chest pains or heart attacks. The condition where high levels of cholesterol are passed through the family is called familial within the family, hyper, meaning high, cholesterol pertaining to what we're talking about, and emia, meaning blood. So familial hypercholesterolemia. Well, it is important. This condition can affect 1 in 300 people in the population, so it's incredibly common if you step back and think about it. And it's very, very common in people who have heart attacks. The reason it's so important to diagnose familial hypercholesterolemia is that it can be treated before a heart attack occurs. The use of cholesterol-lowering drugs and monitoring through coordinated specialist and local doctor care can make a real difference to the life of these people, such that they can expect a normal life expectancy, not suffer a premature event. So, if there is premature coronary artery disease in the family and high cholesterol levels, get checked out and talk with your local doctor about it. With appropriate diagnosis and treatment, it is an opportunity to make a real difference, not something to be scared of or put off. In some families, however, it is not always clear what the cause of early coronary disease is related to. These families may have a clear history of premature coronary events, but the cholesterol levels may not be particularly high, and other risk factors may not be obvious. I do see patients in this situation regularly in my rooms. They want to know, are they at risk as other family members? This can be difficult to sort out, but often I speak with these patients about further testing to try to more precisely evaluate their risk, and frequently discussing use of CT imaging to look directly at their arteries to help in understanding the health of their arteries. This testing is not for everyone and may incur an out-of-pocket expense. However, I have many patients who wish to undergo the testing for their own clarity around their own cardiac health. When it comes to familial heart conditions, it is often the case that the apple doesn't fall far from the tree, and to be aware of an appropriate diagnosis, if present, and then implement appropriate treatment can be life-saving. Well, that concludes this episode. Thank you for joining me. I hope you feel educated and informed, and I'm sure you're looking forward to the next heart-throbbing episode. Until next time, please don't die of a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover or a paperback, and an audio from Amazon or wherever good books are sold.